Hello, everyone. My name is Noel Watson. I am a member of the Program Committee for the Global Health Supply Chain Summit. I'd like to welcome you to one of the first of our presentations, webinar presentations, track 2 on COVID-19 vaccine delivery. We have 3 great presentations for today. The first of which is delivering health products and services in markets others don't reach. Second is Africa's COVID-19 vaccine supply chain and logistics readiness. And the third is enabling pharmaceutical traceability in Nigeria using GS1 global standards, looking at a case study of implementing lean traceability for AstraZeneca's COVID-19 vaccine and Moderna vaccines within Nigeria. Just a little bit about how we'll proceed through the next hour or so. Each presenter has about 17 minutes. Some presenters have submitted video presentations that we'll play. The participants can ask questions after each presentation, and we have roughly around 5 minutes of Q&A. I think this Q&A will be done. Folks can unmute themselves and ask. Is that right, Jean-Marie? Okay.
That is correct, yes.
Oh, actually, if you have any questions or concerns during this track, I can send a chat to me and I can deal with them. So with that, we will maybe I should cover this as well. There's of course muting and unmuting. If you do have a question, and maybe the presenters, if we're not doing a video, if we're doing a video, then you'll definitely have to put your question in at the end. But if we have a live presenter, you can type in the chat box or raise your hand so that I can call on you with a question. And then at the end, we may also have a little extra time and can do a general Q&A. So with that, we're going to hand over to our first presenter on delivering health products and services in markets others don't reach.
Hi everyone, I'm Rich Bryson from Health Tech Social Enterprise Reach 52. Through our health platform, we deliver health products and services in the markets others don't reach across low and middle income countries in South and Southeast Asia and East Africa. And today I'm going to talk to you about why and how we do this, starting with one of the communities we operate in the rural Philippines. I'm going to start by talking about Nolita. So Nolita lives in the Western Visayas, a rural market in the Philippines. She lives on a family household income of $3 to $7 per day, lives in low resource settings with weak health systems and a lack of health workers. The rural health centres may have some medicines, but are often out of stock. And there's just a lack of basic diagnostics. So Nolita's communities can't access basic rapid blood sugar tests for diabetes, for example. And she also lives in rural regions that are over an hour from pharmacies and clinics that provide the medicines, diagnostics that her family and her needs. But unfortunately, the prices are often also very hard to afford. And whilst clearly every community and in every country is different, there are billions of people like Nolita living in low resource settings who have multiple barriers to getting the essential health products and services they need. Over half the world's population still can't access essential health services, according to the WHO, and that's been exacerbated by the pandemic, clearly. So we need to be really honest about this. If health products and services don't effectively reach billions of people on Earth, billions of people who need these products, and as I'll come on to, if we make them accessible and affordable, will pay for them, then this is a big weakness in the global health supply chains that must be addressed. And to address these weaknesses in healthcare systems and last mile supply chains, we must build new solutions from the ground up. And from my perspective, there's 3 C's that are absolutely essential to achieving this. Firstly, we must ensure the solutions are community-led so that they address the gaps in traditional health infrastructure and supply chains by working with and equipping the communities themselves to run the services for their communities. And that means partnering with community leaders to design the systems that work for the communities, equipping community health workers, and equipping community members as informal healthcare providers. The second C is connectivity. You need to connect the patients and these community health teams in low connectivity areas to the health systems and supply chains in the country, so the needed health products and services can reach them. And health technologies, where my organization is really focused, can provide the means to do this and overcome a lot of the traditional gaps. But we need to remember many of these regions have low to no internet. Over 3 billion people in the world still offline. And even if they are connected, sometimes the digital literacy levels are very low. So we need to accelerate this in terms of internet connection, and there's a role for policy, government regulation. So good example, India's Universal Service Obligation Fund, which was used to build fiber cables into rural and remote regions across India, through which the telecom service providers paid 5% of their adjusted gross revenue to support the initiative. But we can also do this through offline first health tech platforms. And that means equipping roaming community health teams with applications and devices that they can use to manage services, process orders in the community offline, and then sync the data and share appropriately with partners on the platform. And that's, as I'll come and talk about, is what we've really focused in on. And the final C is collaboration with these different partners across the system. If you've got the platform that enables different health services, you've got community teams to run it, you've got to bring together all the different players in the system to provide the value they bring. And it's got to be in a way that creates value for all in the system and all the actors in it. And that means the manufacturers, it means distributors, pharmacies, retailers, as well as working with governments and providers, and of course, the communities themselves. And it's these 3 C's I've just described that very much underpin the health tech platform solution we've built, that we're delivering and that we're looking to now rapidly scale up across different countries to make health systems and supply chains go further. And in terms of community-led systems, what we do is we first of all equip community NGOs and teams of community health workers and members of the communities as networks of agents with our offline first mobile apps to run different health programs, ensure time referrals, and process to manage the delivery of medicines as well as everyday health products into the last mile. And we've now got over 500 agents in our network across different geographies. We then enable connectivity in the system by providing these community teams with mobile apps to run the service, enabled by the Reach 52 Access Offline First platform. And this platform supports a full range of health services in low connectivity regions. So that's e-learning to train up health workers. It provides the means to engage and educate on different health conditions, provides screening and referrals to the public health providers, and then critically run an e-commerce and logistics service for affordable medicines and insurance and different health products into the last mile. And this is all fueled by collaboration. So through our platform, we bring together different actors in the system. So that's collaborating with governments and public providers. We equip and digitize NGOs that are already trusted to run services on the ground, and that enables us to launch really quickly into new geographies. And then we'll work with different private businesses to expand access to health services and extend last mile supply chains through our model into previously unreachable markets. And at the moment, we're currently implementing our platform and products across the Philippines, Cambodia, India, Indonesia, and Kenya, and are working with different organizations and governments to expand access to health services and products across non-communicable diseases, infectious diseases, maternal and child health, and consumer health. And what I wanted to do today was just to share a couple of practical ways we're doing this already. And so that's what I'll do now. So the first of which I was going to focus on is our new digital healthcare model for non-communicable diseases in rural populations in rural Philippines. And non-communicable diseases, or NCDs for sure, account for 60% of global deaths every year, with the largest burden in low and middle income countries. However, health system services in these areas for preventing, screening and treating NCDs remain really inaccessible to many people. So, for example, in the Philippines, cardiovascular disease is the single largest cause of mortality in the Philippines, accounting for 33% of total deaths. As I mentioned earlier, there's a lot of significant health system weaknesses. Residents live on family income of $3 to $7 per day. They're long distances from healthcare providers. And there's just a lack of basic access to the medicines and screening that's needed, as well as chronic shortages of health workers. So what this new digital health model was designed to do was address this challenge for diabetes and hypertension. And it was developed in collaboration with Medtronic Labs, and it was called Podial, which means to keep progressing. And it's a fully integrated health solution for low-income patients, providing coaching, testing, and medicines in one accessible subscription service. And this service overcomes some of the traditional access barriers in lower income, lower connectivity populations through this combination of offline first technology with community empowerment and involvement. And as a result, patients are able to pay out of pocket for the service. It's a monthly subscription service in the community, and it's much more affordable than current options available to them. And if we link back to the 3 C's, you can see how this relates. So community health workers and public health nurses provide the coaching and the screening. Community members equipped as networks of agents with the offline mobile apps to manage the ordering and delivery of medicines based on prescriptions into the villages. And the key to this was the integration of the service, the solution. So you've got the coaching, diagnostics, and medicines together. And that was really enabled through the collaboration, working with government bodies, different providers, businesses, and non-profits. And as a result, even in these low income regions, the Podial subscription service was oversubscribed by 33% and achieved 60% lives improved. That means 60% of enrollees were able to put their previously uncontrolled blood pressure and or blood glucose levels into a target range in at least 1 point through the program. So just to summarize in practice how this works on the ground, firstly, it was partnering with local government units in the relevant provinces and municipalities. This is not just about getting approvals to run services, but actively partnering on the model design, integrating with the public health providers and working really closely on the implementation. So this government collaboration is absolutely critical in all cases. Secondly, we equipped the nurses and the community health workers as the health coaches. So they provided the bi-weekly coaching on diabetes and hypertension prevention, the treatment and management, all in the community, and supported by the diagnostic suppliers across our platform. And then it's by strengthening the health system through the education and screening that we're able to identify a patient population with needs for particular medicines. And through our model, the community members, as mentioned, are trained up as agents who use the Reach 52 Access e-commerce application and service to process orders based on the prescriptions provided by doctors, and then manage the deliveries into the communities in partnerships with the pharmacies who receive and manage orders also through the platform. So it's essential, in my view, to address the whole system if you want to drive sustainable impact. We found it's far less effective to provide access to medicines through agents and pharmacies if you don't integrate it with the health education, the screening, collecting data to really pinpoint the needs. So it's really incumbent on everyone involved to work together to develop the whole system, not just to try and extend your supply chains in your areas. The second example I wanted to talk through the work we're doing is in a very urgent area where we're leveraging our platform to extend supply chains to support COVID-19 vaccine rollouts. As of the November the 29th, clearly there's still very significant issues in ensuring vaccine rollouts reach everyone. This is not just about the supply, it's also as much about ensuring the delivery systems enable the vaccines to reach all the people that need them. So as mentioned, as of the end of November, around 8 billion COVID-19 vaccine doses have been administered to people globally, but only 6% of people in low-income countries have received at least one dose of the vaccine. Now, this is clearly, as many of you will be aware, a huge challenge requiring governments, businesses, multilaterals to work together. But what we've done is to look at how we can leverage our platform to accelerate the vaccine rollouts in the last mile in the offline rural regions that we're focused on. And there's some real barriers to the reach of vaccine rollout programs. So rural populations often are unable to book via online vaccine systems. There's a lack of information on how to book. There can be misinformation about vaccines, and this all hinders the uptake. And in some cases, you can end up with vaccine supplies expiring. And the manual processes being used are just too slow and inefficient, often where we're working. So in rural Philippines, you find community health workers trying to arrange with residents on the phone, having to live everything in a very manual way, which is just too slow and inefficient. And what's really needed are more tech-enabled, community-led solutions to accelerate vaccine rollouts into these patient populations. So what we've created is an integrated solution for vaccinations in low resource settings enabled through the Reach52 Access platform. This integrated solution combines two elements: an offline first app for health workers and an automated SMS, or it can be instant messaging gateway for patients. So as with all our solutions, the offline first apps work in even low connectivity regions. So patients at a vaccination site are registered by the health worker, the details recorded, and then patients receive their message with their unique code linking to details about their vaccination dose, and then reminders on when and where they will receive the follow-up. And then the code is then used for the second dose administration. And critically, what it also enables is vaccine stock tracking. It enables forecasting for each district, adverse event reporting, and data recording that can be shared with the relevant health management information systems. And all the health tech applications, as with everything we do, is designed to be low spec, so it can work on lower spec devices and for lower levels of digital literacy. So just to go through the pathway, so clearly coordinating vaccine rollouts in low middle income countries is complex, a complex series of activities. One of the most difficult from our experience is that point between regional distribution hubs and last mile delivery. And equally, for those operating in this space, you'll know that administration and monitoring can also be very difficult in these regions, rural regions. So just to confirm how the pathway works, patients register in the provider app. The first dose is digitally recorded. The patient receives a QR or alphanumeric code after the first dose, and that links to a personal record in a secure database. The provider app updates with available and needed vaccine stock. You can adjust forecasts, you can manage supplies, and then delivery into the regions where the vaccinations are needed. And patients then receive a reminder for their second dose via SMS or instant messaging. The patient code is scanned by the provider app, and then the second dose is administered, and stocks are continuously tracked and supply optimized. So it's very much community-led, it's tech-enabled, and the goal is to close this supply chain gap between regional distribution hubs and last mile delivery to the patient. And the intention with the right partnerships is that we can support the efforts of governments, businesses, multilaterals to accelerate vaccine rollouts across low middle income countries for COVID-19. And we're currently planning pilots with government partners in regions where we operate, but also looking for other partners to be able to accelerate the vaccine rollouts where it's needed. So to summarize our impact so far in extending and making supply chains go further in low middle income countries, we've now got over 900,000 users enrolled and connected to the health platform for our networks of agents. And we've got a target of over 1 million by the end of the year. And what we're doing is we're collecting data, we're providing health services and products to meet their needs, as I talked through with the Bedian model earlier. And our goal is really to establish systems and models that address the health and access needs of populations in a really sustainable way. So delivering both social and commercial goals. And for example, we've demonstrated that for every $1 invested in Reach 52, we create $2.10 worth of social value for our markets and our communities. And we're now operating across 5 countries and with expansion planned for 2022 through the platform. So finally, just to really summarize, how can systems and supply chain models be established and scaled for delivering health products and services into markets others don't reach across the world? Well, it's just a recap. It's these 3 C's that are critical. Ensure the solutions are community-led, establish connectivity, and enable collaboration between all the needed actors in the health system. So many thanks for listening, and please get in touch if you would like to talk more.
So I think Rich is with us. Rich, can you unmute? And Rich Bryson is the Chief Strategy and Market Officer at Reach 52. So Rich, I wanted to, did you have any just final comments to add to the video? While folks, you can, if you have questions for Rich, you can raise your hand and or type into the chat and we'll get to you. So Rich, thank you so much for that presentation. Any additional thoughts to add?
No, all good. Please go ahead, Noel.
Excellent. So any questions from our audience? There's Rich. Any questions from our audience? If not, let me pose one to you, Rich, and this is great and excellent. So how do you, is about the process about how Reach 52 thinks about going into another country? How do you select a country? Like, what are you looking for in terms of partnerships on the ground? And then what are some of the timelines involved in terms of making progress? Could you say a little bit about that? Yeah, thanks, Noel. So the intent of Reach 52, so the 52% actually in the name of Reach 52 relates to the WHO statistic a few years ago around the fact that 52% of the world still can't access essential health services. So our focus is in enabling the scale, so scale and sustainability, and that requires us to really work with a whole range of different partners. So we work with governments, we work with businesses, non-profits. And in terms of the countries we're focused on, there's obviously multiple weaknesses and gaps in health systems across a number of low and middle income countries. There's multiple gaps, and what we're looking to address through our platform is a system solution to be able to address those weaknesses. So, as I talked about in the presentation, the platform enables us to enable the gaps in health education, the screening, health worker training through remote channels, and then the delivery of the medicines or vaccinations into these populations. So we have a health system solution through the platform. But then in terms of being able to deliver it and be able to rapidly scale into new geographies and countries, we work with existing community-based organizations. So we call them in our language, growth partners. Sorry, what partners?
Growth partners. So we talk about growth partners because ultimately what we're doing is helping to grow the communities, grow the partners with the community-based organizations that we work with through access to the health services they need. So some of the countries I talked about, like Kenya most recently and Indonesia, that's come about through identifying existing community-based organizations, non-governmental organizations on the ground, and we then equip them with our platform. We provide the necessary training with the apps, but also to be able to deliver certain services. And they will then deliver those services on the ground. And that often starts with collecting data on those populations so they can act, rather than just saying this is what we're going to give to you in terms of health programs, collecting actual data on what the needs are of particular populations so that we can tailor the health programs and services that we're providing to those communities. And so that's very much been our model for Cambodia, for India, Indonesia, and Kenya, and going into new countries next year, that will be the model as well. And what that enables us to do is rapidly deploy. It enables us to do it in a more scalable way because it doesn't require us to be on the ground. We're working with existing partners, and by, as I say, by collecting that data, it means we can then work with governments, we can work with leading healthcare organizations, both public and private sector, to design the right type of programs that are needed in particular populations, because obviously population needs vary and the health system needs vary. So that's really our focus, Noel. It's about,
And what are some of the timelines involved? What are some of the timelines for collecting that data, for training these growth partners, and for finally going live with the program?
Yeah, I mean, we can do it relatively quickly because we have the platform. It's really about finding the right partners to work with. So we have an ongoing focus to identify non-governmental organizations we can work with, and provided we can find those right partners, we equip those partners with the platform, with our capabilities to go and run services within 3 months, a kind of 3-month type period. So it's really about finding the right partners to be able to work with, enables us to move quickly.
Excellent. All right, I'm not seeing any hands or comments in the chat. So Rich, I think that meant that everything was done very clearly, and we can let you go. You'll probably be around for the networking afterwards. So folks, if you do have questions, you can reach out to Rich later on. But thank you so much, Rich. Appreciate it.
Okay.
Next, the next presentation, let me get myself sorted out here. The next presentation is on Africa's COVID-19 vaccine supply chain and logistics readiness. I think this is from Pamela Steele Associates. And I think we do have Joanna Naylor here from Pamela Steele. Joanna, I don't know if you wanted to say anything just before the video starts.
Yeah, hi everyone. I'll just say a quick word, so I don't think I actually mentioned it in the video, about Pamela Steele Associates. We're a niche consultancy company with a focus on strengthening the health supply chain in low and middle income countries. And we work in consultancy and health supply chain strengthening projects. And we also do training, and we also do research, which is the department that I'm part of. So yeah, I think everything else should be explained in the video, and then I'll be around afterwards if you have any questions. So yeah, thanks for listening.
Excellent, thanks, Joanna. And off we go.
To the presentation on Africa's COVID-19 vaccine supply chain and logistics readiness by Pamela Steele Associates. My name
Jennifer,
is
it's a little low. Can we turn it up?
Associates at Pamela Steele Associates, and I'll be taking you through this presentation today. So to give an outline of this presentation, we will start with introduction and context, then followed by methodology, then we will look at brief results from the literature review, then we will look at results of the survey, then we will look at recommendations given by the respondents, and we will finish with a summary. The COVID-19 pandemic has had a devastating human impact and exerted unrelenting pressure on pharmaceutical and healthcare supply chains. And existing research has shown that low and middle income countries, especially African countries, are particularly vulnerable to the indirect effects of COVID-19 on their supply chains. Now, vaccines are widely viewed as one, if not the most important, critical step to end the ongoing pandemic. And at the time that data was gathered for this paper, in February and March earlier this year, COVID-19 vaccines were beginning to be distributed globally. And it was estimated that African countries will require around 1.5 billion doses to vaccinate at least 60% of the population, which is the amount estimated to achieve herd immunity through vaccination. At the time research was conducted, there were numerous supply chain barriers in different African countries, which included funding gaps, weak health systems, poor supply chain infrastructure, and undefined vaccine eligibility. So the delivery of COVID-19 vaccines to African countries therefore requires ensuring that there is optimal supply chain readiness, including thoughtful planning and unprecedented coordination across a wide range of stakeholders. So within this context, our study investigated logistics and supply chain readiness of African countries to support the rollout of the COVID-19 immunisation programme. This offers key insights and lessons to guide both the rollout of the COVID-19 vaccine in African countries and to improve resilience and preparation of supply chains for future pandemics or external shocks, as the UN has estimated that future pandemics will happen more often, kill more people, and cause worse damage than the current COVID-19 pandemic. This research also mainly focused on what happens with vaccine distribution once vaccines arrive in country, so it doesn't dig into the also extremely important issues of difficulties in procurement, vaccine hoarding, manufacturer delays, etc. It should also be emphasised that the primary research took place in an earlier phase of the pandemic. However, it's still important to look at supply chain preparedness in a context where African countries are still to vaccinate the majority of their populations against COVID-19. And as of October 2021, only 15 out of 54 African countries had reached the 10% fully vaccinated target, and half of all African countries had vaccinated less than 2% of their population. I will now give a brief overview of the methodology of this research. This research was conducted in February and March 2021, and it involved two parts. The first part included a literature review of relevant literature relating to the impact of COVID-19 on health supply chains and challenges for the vaccine rollout. This included peer-reviewed articles as well as global project reports and studies. So the primary part of the methodology involved an online questionnaire administered across a wide range of stakeholders, particularly logistics providers at the central, district and state levels in African countries, as well as from implementing partners and private sector participants in the health supply chain. Invitations to complete the survey were circulated through multiple channels, including the IAPHL platform and the PSA-led South-South Knowledge Exchange Network. The survey asked respondents to rate their preparation across a range of factors and included questions on the impact of COVID-19 on supply chain operations, resilience of operations, the preparedness of health supply chain participants, and issues around vaccine logistics. The survey received 41 responses, 88% of whom were from Africa, 10% were from Asia, and 2% were from South America. As is shown in the diagram, 41% of respondents were from organisations at the national level, 15% were from the state level, 5% were from the local level, and the remaining 39% listed their organisation as other, which included private sector, non-profit, and the self-employed. Now I will give a quick overview of the results from the literature review. The literature review identified the need and goals for vaccine planning in Africa. African countries will require around 1.5 billion doses to vaccinate at least 60% of the population, as well as identifying existing tools to help countries prepare, such as the WHO UNICEF Gavi Vaccine Readiness Assessment Tool. The review also identified key areas of the COVID-19 vaccine supply chain, so that data collection could measure the readiness of respective African organisations against these areas. The key supply chain areas from the literature review are listed here and include plans for how vaccines will be imported, stored, managed and distributed, including vaccine arrival, storage, cold chain capacity, as well as plans for appropriate infrastructure to be in place, including facility layout, security, power backup and technical support. And vaccine management policies were also identified as a key area in the COVID-19 vaccine supply chain. The literature review also identified support areas for the COVID-19 vaccine supply chain. They are also listed here and include standard maintenance systems, use of a logistics management information system, having sufficient and well-trained staff, regulatory frameworks, contingency planning, and secure funding. So we will now move to a brief summary of the main results from the research. One key finding was that overall preparation levels were mixed. On the one hand, around 2/3 of respondents, 65%, either agreed or strongly agreed that their organisation was well prepared for the rollout of the COVID-19 vaccination. However, this left a substantial minority, 35%, who did not agree that they were well prepared for the rollout of the COVID-19 vaccination. And moreover, fewer than half, only 41% of respondents, stated that they had a plan in place for procuring COVID-19 vaccines. This slide shows the areas which respondents said they were most strongly prepared for, with the percentages listed in brackets indicating the number of people who either agreed or strongly agreed that they were prepared in each area. So within key areas, this included vaccine management policies, as shown in the diagram, where 64% of respondents either agreed or strongly agreed that they were prepared. Vaccine transportation, where 61% agreed or strongly agreed that they were prepared. And within vaccine support areas, the research showed that respondents thought they were best prepared for forecasting, maintenance systems, monitoring and evaluation, and communication or reporting channels. This slide shows the areas that respondents felt they were least well prepared for, many of which relate to either HR issues or infrastructure. Again, the percentages in the brackets here indicate the percentage of respondents who either agreed or strongly agreed that they were prepared in these areas. So these were hiring new staff. Only 30% of respondents agreed or strongly agreed that new staff are being hired and trained to support the immunisation programme. Cold chain capacity. Only 36% of respondents agreed or strongly agreed that cold chain capacity at all levels is sufficient, and concern over cold chain capacity was more prevalent for national and state level stakeholders. Facility power backup. Only 30% of respondents agreed or strongly agreed that all facilities have power backup and that a 24-hour support service guaranteeing an electricity supply is in place. And other areas of concern were having a sufficient budget available, ensuring that new staff are well briefed and trained, and the creation and dissemination of a distribution plans. Respondents also highlighted that misinformation and fears around vaccinations were a key challenge, emphasising how ongoing conspiracy theories and rumours were leading to vaccine hesitancy, and also stressing the importance of clear communication relating to the vaccine. To summarise the main results, this research revealed some areas of optimism. Vaccine management policies, vaccine transportation, and LMIS and forecasting were the areas where respondents most strongly agreed that they were prepared. However, human resources, including training and ensuring sufficient numbers of staff, infrastructure, particularly cold chain capacity and power backup, and budgetary constraints were listed as key challenges. Further, respondents did not have an extremely high level of readiness for any of the factors surveyed. Not a single factor resulted in more than 70% of respondents agreeing or strongly agreeing that they were prepared, and of the total 21 factors studied, for 10 of these factors, so around half, fewer than half of respondents could agree or strongly agree that they were fully prepared. There were also high rates of uncertainty. Around 1/3 of respondents were uncertain how prepared their organisation was for each category. As supply chains are built back, it is critical that they are strengthened in terms of preparedness for the ongoing COVID-19 vaccine rollout, as well as preparation for future vaccine distribution, future pandemics, or future waves of the COVID-19 pandemic. The following are recommendations which were listed by the respondents to our survey. Whilst this survey was undertaken at the beginning of the year, many of these recommendations are still relevant now. Respondents recommended a need for greater training, highlighting how decision makers, health workers, and populations should be quickly trained and sensitised on the COVID-19 vaccination. Another area where there were many recommendations was around human resources and staffing. Respondents recommended that organisations hire additional HR for managing products, that vaccines should only be administered by qualified and trained personnel, that pharmacists should be in charge of procurement, and to improve low turnout of health workers, they should address the health workers' fear of infection. Further recommendations from our survey included recommendations in the area of infrastructure, that COVID-19 vaccine supply chains should be integrated with existing cold chain management systems where possible, and that COVID-19 vaccine storage facilities should be procured as a priority. Recommendations relating to governance. Respondents recommended that governments should ensure optimal distribution and storage, and that there should be transparency in planning and distribution. Recommendations relating to communication with the public. Respondents recommended that there should be the rollout of risk management strategies to address ongoing COVID-19 vaccine hesitancy. And they also recommended that awareness campaigns, for example, through radio, television, and other forms of distribution, should be made available at all levels to share information. And respondents also made recommendations in the area of data and M&E, advising that there should be the use of LMIS to manage COVID-19 vaccine inventory for traceability, utilisation and accountability, and they also recommended that a needs assessment should be conducted. So to summarise, vaccination levels in African countries are still low. Around half of African countries have vaccinated less than 2% of their population. And whilst African governments being able to procure and receive vaccinations is a critical issue, this research focused mainly on supply chain preparedness and resilience in country, focusing on once vaccine shipments have arrived. Vaccine management policies, vaccine transportation, and LMIS or forecasting were listed as the strongest areas of preparation by participants. Around 60% of respondents either agreed or strongly agreed that they were prepared in these areas. Human resources and infrastructure, particularly cold chain, were areas where respondents felt least well prepared, with only around 30% of respondents agreeing or strongly agreeing that they were prepared in these factors. There was also no single factor where more than 70% of respondents agreed or strongly agreed that they were prepared. Respondents also gave numerous recommendations, which included hiring additional staff, integrating COVID-19 vaccine supply chains with existing cold chain management systems where possible, and rolling out risk management strategies to address ongoing COVID-19 vaccine hesitancy. Thank you for listening to this presentation, and there should be now time to answer some questions that you may have. Thank you.
Excellent. So Joanna, if I could ask you to come back to us.
Great.
There you are.
Yeah, I don't really have anything else to add. Just want to say thank you for listening, and yeah, if you have any questions, or maybe there's not time for this, but just any other comments on your own in-country experience of the vaccine rollout, challenges or areas of success, would also be interesting to hear. So thank you.
Excellent. Yeah, so I think we have 5 minutes. So let's see if there are any hands. If not, I had a couple small questions that I'll throw out all at once.
Yeah, of course.
So one, can you see something about the geographical representation of the African responses that made up the majority of your responses there? I think you said it was like 88% were from Africa. So I don't know if you have a sense of the representation. Then 2, was there anything from the results that was surprising to you? You know, you did the literature review that sort of sets up an expectation, and was there anything surprising? And then lastly, from a research point of view, was there a larger sort of research agenda or action-oriented agenda that this particular research fit into? Or maybe I could phrase it another way: how were the results from this project used?
Great, let me just unmute myself. Yeah, thank you. So in terms of the breakdown of the numbers, I'm just trying to get it up now. I know that, first of all, the number of respondents we had, it can't be called, a large-scale comprehensive survey. It was around 40. So I think the research should be viewed more as I guess, an initial snapshot of what was going on, particularly when we undertook the research. It was if we think back, it was in February and March of this year, which was, it feels like a long time ago. It was the time just when vaccines were starting to become available and be approved by regulators and starting to be rolled out to different countries. So we really wanted to do something quite quick and see what the ongoing situation was with readiness there. The majority of respondents that we received were from Ethiopia and Nigeria. I've got the paper here, I can't remember the percentages off the top of my head. Let me try and find them, bear with me one moment. Yeah, so Nigeria was represented quite substantially within the African respondents, which was 88% of the overall respondents. 47% were from Nigeria and 29% were from Ethiopia, and 6% of respondents were each from Burundi, Liberia, Kenya, and we also received responses from Togo, Sierra Leone, Ghana, Chad, Mali, and Zimbabwe. So there was quite a range, but again, it's a relatively small number, and with quite a heavy proportion of respondents were from Nigeria. So yeah, I think it's an interesting snapshot, but to definitely make more, I guess, broad definitive conclusions, then we'd need to do a more comprehensive survey. Yeah, I hope that answers your question. And the second question you said about, was there anything particularly surprising? I'm not sure. I think, to be honest, there wasn't anything that was particularly surprising. I think a lot of the areas of where there was a lack of readiness in the supply chain and where respondents were saying we want to be prepared more in these certain areas, a lot of them are areas that just come up again and again if you're looking at health systems and supply chain research in low and middle income countries, like infrastructure, cold chain, budgeting was a huge one, which obviously underpins basically every other factor. And I guess something which was slightly surprising, because we hadn't expected it to come out as such a large area of concern and lack of preparedness, was in terms of vaccine hesitancy. That was something which we didn't actually identify as an initial factor in the literature review, and then a lot of the respondents mentioned this, that was an area that they're really concerned about in terms of misinformation or not being able to communicate with their populations about their fears of the COVID-19 vaccination. So that was probably the area of the research that was most surprising. But I think, yeah, in general, it was most of the areas that we probably would have expected to see.
Sure. Yeah, I think hesitancy has sort of become a popular term past 18 months or so. Before, academics knew little about it. I'm kidding, but yeah, it definitely become a bit more popular. And then the last thing was about the research, and there was a larger research agenda, or just how this particular project was used.
Yeah, in terms of a larger research agenda, I don't think there wasn't planned, say, to feed into a specific project. In terms of the work that we do at PSA, sort of vaccine rollouts and that kind of area isn't something that we focus on a lot. So the focus of the research was more of getting a quick snapshot of what was going on and sharing the research and sharing it with like practitioners and policymakers and the people within our network, so they could see the situation that was ongoing, and then ideally using that as a foundation to build on how health supply chain resilience can be improved across all areas, not just looking at vaccines, but looking at the whole spectrum of the health system.
Excellent. Thank you so much for that. I'm seeing a hand from Tyler.
Thank you,
ahead,
Joanna. Yeah, thank you, Joanna, for sharing with us. I'm curious, and I think you kind of maybe started to touch on this from Noel's last question. But obviously, you mentioned this research was done at the beginning of the year, and it wasn't something that you were planning to take and turn into a project. But I'm curious, have you, in kind of your own experiences over the last year, seen any projects or kind of implementations from these recommendations, or in your opinion, has any of these areas improved or disapproved over the last few months?
Yeah, thank you. That's a good question. I think it's hard to say. I think I haven't personally seen anything in terms of projects that I've been working on or taking these specific implementations and then them being implemented. And I think if we look at where there's focus on Africa, if you look at it across the continent, it's definitely quite mixed, I think, in terms of improvements since this research has been conducted. As I said in the beginning of the presentation, the overall vaccination levels are still quite low. But within that, there is a lot of variation within countries. Some countries such as South Africa, Rwanda, Morocco, they've managed to reach, it's still, most of them have relatively low vaccination levels compared to, say, within Europe or America, but they've reached their target of vaccinating at least 10% of their population by the end of September of this year. And then some of them have gone even higher through a range of different methods. A lot of which focuses on the preparation and ensuring that there's cold chain facilities at the local level and communicating with the populations and things like that.
Excellent, excellent. And with that, Joanna, I want to thank you for being here and presenting. Thank you so much.
Thank you. Thank you, everyone.
Excellent. So now, getting myself situated here again, our third presentation, enabling pharmaceutical traceability in Nigeria using GS1 global standards, looking at some key studies with AstraZeneca and Moderna COVID-19 vaccines. I think John Coyote will be presenting in person, or is this a video? This is in person, right? John, are you there?
Yes, I'm here.
You are here. Excellent, excellent. So I'll hand over to you, John. I think you're doing this with your professor, Professor Adeyeye, and I'll hand over to you, and looking forward to it.
Thank you very much. I'm going to be presenting this. I'll be making this presentation on behalf of Professor Moji Adeyeye. She's unavailable today, but I'll be talking on enabling pharmaceutical traceability in Nigeria using GS1 global standards. Some of the implementations we did based on the 5-year implementation plan for traceability in Nigeria. Next slide, please. So I'll be looking at the introduction, the objectives, and the methods that we use to carry out the link traceability for the AstraZeneca COVID-19 vaccines and the in-country serialization of the Moderna COVID-19 vaccines as the case studies. I'll also talk about the schedules that we implemented and the data analysis, show some tables on the results, a few discussion and conclusion. Next slide, please. So the pharmaceutical supply chain in Nigeria is bedeviled by quite a number of challenges. One of them, or notable among them, is the issues of theft, diversions, infiltration of substandard and falsified products. And this, they tend to threaten the outcomes of health interventions, especially when you consider the huge investments that go into this, into the ensuring that some of these commodities are distributed within the country. But the National Agency for Food and Drug Administration, NAFDAC in Nigeria, is the Food and Drug Administration of Nigeria, and the act that sets up this organization puts the burden of drug distribution, the control and regulation of drug distribution, the sale, use, and security on the agency. And as a result of that, the agency is taking bold strides to ensure that we implement pharmaceutical traceability in Nigeria. And that has gone through quite a number of remarkable events, right from the creation of the strategy for pharmaceutical, the national strategy for implementation of pharmaceutical strategy in Nigeria, as well as the launch of that pharmaceutical strategy, the development of a 5-year plan, engagement of stakeholders to the setting up of a governance structure, and to the implementation of various pilots. So the implementations I'll be describing in this presentation is based on some of the pilots that were conducted as follow-up to the activities that we have lined up in our 5-year implementation plan for implementing pharmaceutical traceability in Nigeria. And the agency, NAFDAC, implemented a lean traceability in conjunction with the National Primary Healthcare Development Agency. That agency is the agency that is responsible for the immunization activities in Nigeria. And they are also the agency that is actually distributing the COVID-19 vaccines and also involved in the distribution of the dispensing of the COVID-19 vaccines in Nigeria. So we work together also with the GS1, the global standards for traceability. The GS1 standards are the most widely used standards across the world, and Nigeria has adopted the use of the GS1 global standards for implementation of traceability also in Nigeria. So NAFDAC worked in collaboration with these organizations to ensure that we are able to, first of all, implement just an traceability for the very first tranche of the COVID-19 vaccines we received in Nigeria, which is the Covishield brand from manufactured by the Serum Institute of India. And we're able to track that through the supply chain. Because we made a commitment to ensure that we're going to be tracking the COVID-19 vaccines through the supply chain in Nigeria, we received from the COVAX facility some donations of Moderna COVID-19 vaccines that were not serialized. And because they were not serialized, they were not traceable, trackable. But because we needed to track and trace them, we had to do the in-country serialization of the Moderna COVID-19 vaccines. So next slide, please. So this presentation is has the objectives, the projects that we conducted, the in-country serialization and the traceability pilot project. You know, we did that just to ensure we're able to learn from that, and so we are able to understand the requirements that you know, are needed for us to be able to deploy a national traceability system, because the COVID-19 vaccines will be distributed across the nation, across the states, down to the local government, to the healthcare facilities. And we had the objective to be able to implement with our supply chain partners and actors a pilot for the traceability of the COVID-19 vaccines, and also to be able to ensure accountability and the safety of the medical products by mitigation of the substandard falsified medicines and prevention of infiltration and diversion by using the GS1 technology, the traceability technology, and also for us to be able to gather sufficient data for, to support the pharmacovigilance activities, and just in case of any other post-marketing recall activities, as the case may be. Next slide, please. So the product of interest for this, so for the lean traceability for the AstraZeneca was the Covishield. I said that earlier. That was manufactured by the Serum Institute, and we were able to identify the product. Crucial to any traceability activity is identification of the product. And we're able to identify each product by a combination of the global trade item number, the batch number, and the expiry date, and the serial number. So this is unique for every individual secondary pack, and our traceability was done at the level of the secondary pack. So for us to be able to track and trace these products across the supply chain, we needed to also ensure that there was GS1 standards recorded or registered for the facilities. And for this particular lean traceability for AstraZeneca COVID-19 vaccines, we're able to, at that time, register over 400 facilities in 36 states. Currently, the registration has gone up to quite a number of thousands now. But as at the time of this first study, we were able to register over 400 facilities across 36 states and the Federal Capital Territory. And these facilities belong to either the national, state, the local government, and some particular healthcare facilities across the supply chain. Next slide, please. So we also conducted the scanning of the GS1 barcode. Next slide, please. So we conducted the scanning of the GS1 barcode on the secondary packaging, because the primary packaging didn't come with serialization, and that would be even very extremely difficult if we didn't get the serial numbers directly from the manufacturers. So, but upon the entry and across the 34 states of Nigeria, and the state code stores and the Federal Capital Territory code stores and some selected local government stores, we were able to scan the GS1 barcodes. And the scanning activity helped us to gather data of the movement of this product. So this data is able to provide us visibility of every secondary pack at each time within the supply chain. And then we did a detailed analysis of the reports available on our website. The link is there. Next slide, please. So we had this supply chain map that we planned out, where we're going to be scanning the vaccines. The vaccines, because of to enable control, proper control, we ensured that the entry of the vaccines into the country was from just one location. That was the Abuja International Airport, the Nnamdi Azikiwe International Airport in Abuja. And at that point, we restricted the entry of COVID-19 vaccines to only that location, so that it's easy for us to control the distribution. So we were able to scan at the port of entry where the vaccines were moved to, because of the central warehouse is almost in the same location where the airport is. It's a strategic cold store, and the vaccines were moved to that place. So we now scan every secondary pack of the vaccines at those points to be able to commission those barcodes on our electronic systems. So from the central warehouse, there was distribution to different state warehouses, 37 states. Although for this pilot, not all 37 states were able to scan, we were able to have good data collected from 34 states. Excuse me. And some of the states where we were unable to get was due to some logistic reasons and some other challenges. But we were able to also scan at least in at least a local government from every state, because it was a lean traceability. As of today, we have been able to scale to a number of local governments, but as at the time of this study, we scanned to at least one local government per state. And we also scanned to some selected healthcare facilities. So we planned that there were going to be active pharmacovigilance sites in some of those states, and we were able to also go and decommission the packs that were used by scanning in those locations. Next slide, please. So for this in-country serialization of the Moderna COVID-19 vaccines, we received these 7 batches of these vaccines from the USA, but that was about 4 million and 80 doses, and we had about over 28,000 packs. And the issues that we had was when these vaccines arrived, the GS1 barcodes on them did not carry serial numbers. And we had some issues with the human readable expiry date on the vaccines, and they were not encoded in the GS1 standard. So for us to be able to track this across the supply chain, we needed to create our own in-country serial numbers that complied with the GS1 standards, so that we can scan this across the states and across the different points in the supply chain to be able to provide us visibility of the products and to be able to guide against or help us to detect if there's any potential infiltration. Next slide, please. So I'll talk about the implemented schedule. For the lean traceability of AstraZeneca vaccines, we started the preparations around October 2020 to about January, where we developed our proposal we had a call to action to confirm, to network with all the different stakeholders, the primary healthcare, the GS1 Nigeria. We did some information gathering. We designed how we're going to try and implement the activities. So we developed a protocol in February 2021, and we're able to purchase some hardware scanners that we used at the central cold store to scan. And then we had to deploy the mobile application that was to be used across the different location points that we scanned. And then later, when the vaccines came in March, between March and April, we did the commissioning of the vaccines using the serialization that was the barcodes carrying the serial numbers. We captured the event data around it and we scanned it. By May 2021, we were able to do the analysis of the results, the data we gathered based on the scanning. Next slide, please. So for the in-country serialization of the Moderna COVID-19 vaccines, what we did was we had to do some preparation to gather the data about the batches. We had 7 batches. We chose our serial number pattern, and what we used was alphanumeric random numbers, and our serial number character was 8, between 8 and 10, and we created our encoding. Then we did a serialization to include the GTIN batch number, expiry date, and serial number that were coded in GS1 standards 2D matrix barcodes. We printed this and we commissioned them to our systems because we're dealing with cold chain products, and then we now had to label them, and it took us about 3 days to label them. Excuse me. So these vaccines were stored in the ultra cold freezers. So it just took us very short time for us to bring them out of the freezers, to label them and return them back to ensure that we didn't break the cold chain. Next slide, please. So our data was analyzed. We used our language and environment for statistical computing. We did a preliminary data management to clean up the data and to look at the data scan errors, because when we scanned data, there were some errors based on the data capture because of the devices that was used. We did some exploratory analysis to show the structure and the distribution of the data attributes. And then we only included scan data that had the correct electronic product code in the right format. All the ones that was not captured properly, maybe as a result of the devices that were used across the supply chain, was excluded. So we're able to show, next slide, please, that we, out of a total number of 3 out of a total number that we expected in our shipment, over 3,924,000 doses, we were able to commission 3,836,000 doses, about 97.76%. So the gap within this was either as a result of scan errors or as a result of omission of the packs, because ordinarily we are supposed to have received this the data for the serial numbers from the manufacturers. But because this data was not available, we had to scan each individual pack. And this shows us that we need to collaborate with the manufacturers to provide us the data right at the point of manufacture, because it's quite a laborious activity trying to commission all those large number of packs just by scanning. So we had a total number of 3 batches, and we were able to have a total number of 15,997 scans, where 83% of those scans were valid scans. Next slide, please. So we show the distribution of where we had the valid scans across the nation, and you will see about just 3 states are showing where there were no valid scans. But if you look at the barcode scanning activity, you see that one of those states but all the scan data were invalid. Next slide, please. So the next slide showed the table of results for the in-country serialization of the Moderna vaccines and the various batches. We had the total number of 7 batches, and then we're able to commission a total number of 3,796,240 doses out of the expected 4 million doses, a percentage of 94.9% scanning for commissioning at the cold store. So the data that we collected shows that there's still a gap, the gap in what we are commissioning. For us tracking it, we now have that margin of error to ensure that when the products are being scanned within the supply chain, we look out for that margin of error. So if we are getting scans that are above that margin of error, we can quickly begin to look at the patterns. But ordinarily, event data that was not available to us prior to the arrival of these vaccines was what caused us to engage in the scanning of all the packs and commissioning of every single secondary pack during our port inspection activities. But the traceability implementation, like I described earlier, also had some limitations. We didn't have enough resources to ensure that there was mobile Android-enabled scanners across all the states and local governments, and that also led to the invalidation of some of the scans that we received. We talked about training of stakeholders. We realized that we needed to train them more so that they would know and be able to identify the proper barcodes to scan. And the success of the in-country serialization for the Moderna vaccines, it had enabled us to be able to do the scanning across the supply chain. And it even enabled us to be able to do a regulatory recall as a proof of concept for our implementation. Next slide. So I will conclude by saying that the linked traceability of AstraZeneca COVID-19 vaccines provided the visibility of the movement of the vaccines across the supply chain in Nigeria. And the success we had in the in-country serialization also enabled the scanning of the vaccines along the supply chain to support traceability. And this data we gathered is used to support our pharmacovigilance efforts, and it's also used to support the activities of our monitoring and control of distribution. Next slide. Thank you very much for your attention.
Thank you so much, John. That was very interesting. As a supply chain researcher, many questions, but let me see if there are any questions from our audience. And remember, you can hit on that reactions button and hit raise your hand, and that will alert me to you wanting to ask a question, or you can unmute yourself and just speak. But John, if I could follow up, just a bit of clarification. On one of your slides, you had the difference between a number of vaccines that you started out with and then commissioned. And so, so for example, I think in the Moderna case, it looked like you lost about 5, almost 6, seemingly 6% of the vaccines from what you started with, what you commissioned. And I just wanted to understand what exactly that 6% meant. Were these vaccines that you never actually had to start off with, or were these vaccines that were somehow considered illegitimate and thrown away? What exactly does that discrepancy mean between what you started off with and then what you labeled as commissioned?
Okay, so we had a difference between what we expected based on documentation and what we actually commissioned on site. So the commission is the percentage of what we expected based on the documentation from what we actually were able to commission to our systems. So the commissioning is actually the first port of call, or the first point of information gathering. So we expected 100% of this vaccine, but by the time we commissioned this vaccine, we commissioned 94-point-something% of what we expected.
Okay, so you actually only have that 94.4%. That is all you have. And if you had bought these vaccines, you would have gone back for a refund for the 6% that never arrived.
No, so we now had to identify where did the 6% go. So the 6% could be as a result of failures in scans, because there are some percentage errors in terms of the labeling, and it could also be as a result of omission during commissioning of the vaccines. So what that 6% was going to give to us was a threshold that we must work with. So that threshold, when the vaccines are now being scanned across the supply chain, we must not have vaccines that are scanned or that we cannot detect from what we commissioned that is more than that that threshold that we expected. So that's just for purposes of information, but that's to call our attention to the fact that it is best that we get directly the data from the manufacturer even before the vaccines are arrived. So in that case, we should be getting the 100% of the data. So for logistic reasons, it may be difficult for you to capture every single pack because you are scanning them manually.
Sure.
Yeah, so I think that's what is responsible for the discrepancy.
And then one more follow-up question, if there's no hand raised from the audience. So now, you have this rich data that you didn't have before. And so I can imagine that your folks staring at this data and starting to brainstorm about new ways in which you can use this data. Have you been a part of those discussions? And what are some of the new ways in which folks are thinking of using this data? What are the things that they're looking at this data and saying, hey, we can do this now, which we couldn't do before because we didn't have this granular data? Can you say?
Yeah. So one very important area is the visibility of the products. So one thing this data is going to do for us is it will help us to support our pharmacovigilance activities. You see, the COVID-19 vaccines are novel. This is something that is new, and all the things around the safety is yet to be fully understood because of because it's novel. And for us as a regulator, we are very important. We take it as a very important step to also keep the data of the distribution so that we can look at patterns, just in case we are looking at or finding or observing anything within the populace that we administered. We will have the data to be able to show what particular products, exact products were in those places. Are we going to be able to draw patterns using our data to support maybe the kind of AFIs we are observing? Would we be able to use that data to show that for the COVID-19 vaccines that were distributed in Nigeria, we didn't get infiltration? We are certain that the fake ones that we hear that are being distributed across some countries didn't enter into our supply chain. So we'll be able to use this data to provide answers to some of these intriguing questions that ordinarily you wouldn't be able to find an answer to if you don't have this type of data.
Excellent. No, I appreciate that. So if there are no other questions, I want to thank you, John, for a great presentation and a great project. Applause. We've come to the end of our track session. I just want to give you an update. Following this is a networking session, and that has actually been extended for an additional half hour. So you would have ended at in 25 minutes, but now it'll end in 55 minutes. So looking forward to conversations. I suspect John and some of our other presenters will be there. If you do have questions, follow up, please reach out to them, and hopefully I'll see you there as well. All right, thanks to all our presenters. Again, round of applause, and see you for the rest of the conference. Take care.